Hello, welcome to our talk on cutaneous inflammatory diseases, part 2. I'm Smita Krishnamurthy, and this is a supplement to your reading in the Robbins Pathology textbook. An outline for where we're headed today, we're going to talk about one relatively acute sort of skin disease, which can be associated with infections or drugs, and that's erythema multiforme. Then we'll talk about some more chronic conditions, which usually last for months to years, like psoriasis, seborrheic dermatitis, and lichen planus. And we'll end our talk with some immune-mediated blistering diseases. So erythema multiforme is a hypersensitivity type of reaction. It can either be to infectious agents like herpes simplex virus or mycoplasma, or it can be a reaction to medications. It's thought that there's keratinocyte injury mediated by cytotoxic T cells, and the drug-induced form of erythema multiforme is actually on a spectrum with Stevens-Johnson syndrome, in which patients get extensive involvement of the skin and mucous membranes, or toxic epidermal necrolysis, which is both Stevens-Johnson's and TEN are thought to be similar conditions as erythema multiforme in that they are reactions to medications, and it's just we differentiate them based on the severity, the extent of cutaneous and mucosal involvement, and in TEN you actually get full thickness necrosis of the skin. So these patients, it's almost like a patient who's had a burn. They have extensive sloughing of the skin, and this is a true dermatologic emergency. Patients with TEN, they have to be managed on an emergent basis, because otherwise, if you think about it, the skin is your barrier against the environment, right? So if you have lost significant proportions of your skin, you are prone to getting infections, which can then become septic, and that can be a very dangerous situation. So let's talk about erythema multiforme specifically here. And the clinical presentation, the reason it's called multiforme is because it can look like a bunch of different things to the clinician. So it can look like macules, flat spots, papules, raised lesions, vesicles, fluid-filled blisters, bullae, or the most classic look for it is what we call a targetoid or a target-like lesion. So that's what we're seeing here in this picture. There's the central kind of darker area. This is the region potentially of early epidermal necrosis. And then there's surrounding erythema with a zone of kind of pallor in between, right? So this is the target of erythema multiforme. If you biopsy this lesion, what we see under the microscope is what we call interface dermatitis. Interface meaning that we have lymphocytes which are attacking at the epidermal dermal junction. Okay, so we have, these are your cytotoxic T cells that are attacking down at this junction, and you end up with dead keratinocytes, which is what we're seeing here. These bright pink eosinophilic structures are dyskeratotic or apoptotic keratinocytes. This is the pattern of interface dermatitis, and patients with toxic epidermal necrolysis, which we talked about being a true emergency, we can actually do frozen sections of their skin so that you can get an answer back the same day. And what you will see is full thickness necrosis. So all you can see, I mean, normal skin, these cells need to have nuclei and cytoplasm. Here, most of the nuclei are dead, and it's all just smushy, pink, dead stuff. Full thickness epidermal necrosis. Next, we're going to talk about some diseases that usually last for longer periods of time. The three we're going to talk about are psoriasis, seborrheic dermatitis, and lichen planus or lichen planus. Okay, so psoriasis is thought to have an autoimmune basis. We've talked a little bit about psoriasis in terms of the arthritis earlier in our course. There is a genetic predisposition for patients because certain HLA haplotypes, specifically HLA-C, is closely associated with patients who get psoriasis. And It's thought to be a helper T cell Th1 Th17 interaction with CD8 positive cytotoxic T cells. And as these T cells interact, they secrete cytokines such as interferon gamma and tumor necrosis factor, and also growth factors, which cause keratinocytes to proliferate. You get epidermal hyperplasia, which is what results in the clinical manifestations of psoriasis. The reason these cytokines become important is we now have targeted therapies against those cytokines, which actually cause significant improvement in both cutaneous and arthritic manifestations of psoriasis. So the clinical manifestation is very classic. They are very symmetric, kind of erythematous plaques, which happen on the extensor surfaces of the elbows, the knees, low back, scalp, back of the neck, and they have this very characteristic what's called a silvery white scale adherent to these plaques. Okay, patients with psoriasis can also have nail changes, including kind of these yellowish spots, and they can have onycholysis, they can have pitting of the nails. The skin changes. If you were to lift this scale, this white stuff off of the plaque, you would see little pinpoint bits of bleeding. And this is called the Auspitz sign, which is considered very characteristic of psoriasis. So now let's see what the pathologic view of psoriasis is under the microscope, which closely corresponds to what these things look like. So the scale is always from keratin, right? So because there's all this thick adherent white scale, you would expect to see hyperkeratosis under the microscope, which is what we're seeing here. And if we zoom in on this keratin layer, there are actually nuclei at the top. So this is parakeratosis. Specifically, psoriasis manifests with confluent or kind of end-to-end parakeratosis of the stratum corneum. Next, if you look at the granular layer, it's pretty much gone in psoriasis. You can get little collections of neutrophils either in the stratum spinosum or in the stratum corneum. And you get thickening of the stratum spinosum, which is very characteristic of this disease. So characteristic that we actually call this psoriasiform acanthosis. So if I were to draw a line at the bottom here where all these rete, right, where the skin is coming down, where they come together, they're all about uniform in length. We call that regular psoriasiform acanthosis, and this is what's causing the plaque of psoriasis. It's because the epidermis is thick, the scale is from this keratin. And the other manifestation here, as we look on higher power, you remember we have we call these dermal papillae, where you've got projections of the dermis up here just beneath the epidermis, right? So the portion of the epidermis that's just above the dermal papilla is called the suprapapillary plate. In psoriasis, there's thinning of the suprapapillary plate. And underneath that, in the dermal papilla, you often get dilated blood vessels. The reason I'm pointing these out to you is this is what really accounts for this Auspitz sign that you see clinically. If you lift off the scale, because there is thinning of the stratum spinosum beneath it, you get to see the little bits of bleeding from these dilated vessels. Next, we're going to talk about seborrheic dermatitis, which is another chronic condition. We don't quite understand its pathogenesis, although it's thought to be related to increased sebum production and potentially fungal colonization. The clinical presentation is pretty characteristic. On the scalp, seborrheic dermatitis looks very much like dandruff. And it also happens on the forehead. It can happen on the nasolabial folds right around the ears. And we're looking at it around the ears of this patient. It's all this white kind of scaly stuff. And then there's some erythema or redness associated with it. We don't normally get biopsies of seborrheic dermatitis because it's so characteristic looking clinically. But if you were to biopsy seborrheic dermatitis, it would look pretty non-specific. It would look like a spongiotic dermatitis, which is kind of what we saw in a lot of the eczematous cases as well. In seborrheic dermatitis, we often have parakeratosis around the opening of the hair follicles. You can have some neutrophils up here, but this is not very specific, so it's this combination of the clinical appearance and a spongiotic dermatitis that leads us to seborrheic dermatitis as the diagnosis. Next, we're going to talk about lichen planus. Its pathogenesis is also not completely understood, but it is thought to be another cytotoxic T-cell mediated immune reaction to some form of altered basal epidermal antigen. So the clinical presentation is very characteristic, and it can be remembered by the 6 Ps. So it's pruritic or itchy, purple to violaceous, polygonal, kind of this, kind of plate-like, planar, flat-topped, papules and plaques. So they're raised lesions, and they often happen on the flexural aspects of the wrists. They can happen on the trunk or the genitalia, and they can also involve the mucosa, like the oral mucosa, for example. The other thing that you can sometimes see in these lesions of lichen planus are little white lacy lines. They are called Wickham striae, and again, pretty characteristic. So in this person's mouth, we're seeing these white kind of net-like lacy lines or Wickham striae of lichen planus. If you were to biopsy either the oral mucosa or the cutaneous lesion, we see under the microscope what we call a lichenoid interface dermatitis. Lichenoid just means there's a band of lymphocytes at the dermal epidermal junction. So if we start at the top of the skin, we have hyperkeratosis, and this time it's not parakeratotic, it's orthokeratosis. So remember, in psoriasis, we looked at confluent parakeratosis. In lichen planus, it's orthokeratotic stratum corneum, but that's really what's causing this white lines and kind of this appearance clinically. Underneath that, we have a prominent granular layer, which may also be contributing to the white lines that you see clinically. And then we have acanthosis with kind of sawtoothing of the rete. By that, I mean that these rete have kind of pointed, jagged ends. And this happens because the lymphocytes are attacking the basal layer of the keratinocytes. So you get these dead pink keratinocytes. Sometimes these dead cytoplasm of the keratinocytes will leak down into the dermis, and we call those colloid bodies. But the key here is you have a band of lymphocytes attacking at this dermal epidermal junction. And some patients with lichen planus also have chronic hepatitis C, so that's just something to keep in the back of your mind. We try to exclude that as a possibility when you get patients with LP. Next, we're going to talk about some immunologically mediated blistering diseases. The 3 we're going to focus on are pemphigus, pemphigoid, and dermatitis herpetiformis. Pemphigus vulgaris is an autoimmune disease in which patients get IgG autoantibodies directed against desmoglein 1 and desmoglein 3 in the desmosomes. So you remember we talked about another disease earlier in which there is an infection and a toxin which then damages desmoglein 1. Do you remember what that was? I hope you said impetigo. That was bullous impetigo, in which bacterial toxins damage desmoglein 1. Now we're talking about an autoimmune disease in which we have antibodies to desmoglein 1 and 3. And desmoglein 3 is expressed throughout the epidermis, but specifically in the lower portions of the epidermis. Desmoglein 1 is mainly expressed in the upper portions of the epidermis. So There is a form of pemphigus, which your book talks about, which targets desmoglein 1. Those patients get superficial blisters. But the more common form of pemphigus targets desmoglein 3, and they get blisters within the epidermis involving the basal layers of the skin. So clinically, patients with pemphigus present with flaccid vesicles and larger fluid-filled bullae. They can be anywhere on the skin, and they can also involve the mucosa. And flaccid means that they don't have a lot of substance to them. So they easily rupture, either with pressure or on their own, and they leave behind kind of eroded skin. So here was a blister that's ruptured, and now you're just seeing kind of the red erosion underneath it. And then in this patient's mouth, again, you're seeing erosions from these blisters that have ruptured. Under the microscope, remember, we're talking about antibodies directed against the desmosomes. The desmosomes are the things that hold your keratinocytes together. So if you don't have desmosomal connections, keratinocytes start falling apart. And that's what we're seeing here under the microscope. We call this acantholysis. If you've lost the desmosomes and keratinocytes have fallen apart, we're dealing with an acantholytic process. And this is what's causing the blister that you see, right? The skin is falling apart, and specifically it's an intraepidermal blister in pemphigus, and it happens just above the basal layer. So the basal layer of keratinocytes are attached to the basement membrane by hemidesmosomes. In pemphigus, the hemidesmosomes are intact, so you have a layer of basal cells that sit on the dermal papillae. And sometimes people call these tombstone rows, because you have this dermal papilla and then this row of basal keratinocytes that kind of line the dermal papilla. And then you get the split just above where the desmosomes are. The other thing we can do sometimes for these autoimmune blistering diseases is what we call direct immunofluorescence, or DIF. Essentially, you send 2 biopsies from your patient. You take the first biopsy kind of from the edge of the blister, and then you put that in formalin, and we do a routine process, and we stain it with H&E, which is what we're seeing here, right? And then you can take another biopsy from kind of uninvolved skin or mucosa and put that in a special medium and send that in for direct immunofluorescence. So that piece of skin, let's say your patient has pemphigus. They have antibodies that are bound in between the keratinocytes, right? Because these are the desmosomal proteins. So in the lab, we take that second specimen of skin and we react it with sort of fluorescently tagged antibodies directed against the patient's native antibodies. And then we do a washing step. So if the patient didn't have antibodies, this whole thing would look really dark when you look at it under a fluorescent microscope. But if they do have antibodies, then this is what you see. In pemphigus, because the antibodies are directed against the desmosomes, you have this beautiful, lacy, net-like pattern of deposition of immunoglobulins, in this case IgG, as well as complement, C3, in between the keratinocytes. Very characteristic of pemphigus vulgaris. Next, we're going to talk about another blistering disease called bullous pemphigoid, or BP. This is another autoimmune disease in which patients form IgG autoantibodies, but this time they're targeting proteins in the hemidesmosome. Specifically, these are the BPAGs, or bullous pemphigoid associated antigens, right? So remember, hemidesmosomes are the things that hold your basal keratinocyte to the basement membrane. So it makes sense that the clinical manifestation of bullous pemphigoid is that of tense blisters. Remember, pemphigus was flaccid blisters. They didn't have a lot of substance to them. The pemphigus blisters easily ruptured with pressure. Bullous pemphigoid is a deeper blister. There is the entire epidermis overlying the blister, and therefore these are tense blisters. They're filled with fluid, and they do not easily rupture. Okay? If you were to biopsy one of these blisters, because the antigen is at the hemidesmosomal level, the split happens beneath the epidermis. So we have the entire epidermis intact, and then we have a blister, a space beneath the epidermis. We often have a lot of eosinophils inside the space. It's associated with bullous pemphigoid, but the key is a subepidermal blister, not an intraepidermal blister in BP. And if you do a similar process that we talked about with pemphigus, direct immunofluorescence, where you take a biopsy of kind of more normal looking skin and you put it in a special medium, we reacted in the lab with immunofluorescently tagged antibodies to the patient's antibodies. What we see is a linear band under an immunofluorescence scope at the basement membrane zone, which is where the IgG and complement proteins are depositing in bullous pemphigoid. Our final blistering disease of the day is dermatitis herpetiformis. This is often associated with celiac disease. You remember that is a gluten-sensitive enteropathy. And gluten is the protein that you see in wheat and certain other types of grain. So patients who are exposed to dietary gluten, if they have this disease, form IgA antibodies to the gluten. Those antibodies can cross-react with certain proteins in the anchoring fibrils of the skin. The anchoring fibrils are those little structures which tether the basement membrane to the dermis. Right? So again, we get blisters, but they look very different clinically and pathologically in dermatitis herpetiformis. These are extremely itchy, grouped little vesicles and papules. They're pretty symmetric, and they're often located on the extensor surfaces of the elbows, the knees, the upper back, or the buttock. If you biopsy one of these extremely itchy vesicles, under the microscope, we see collections of neutrophils sitting in the dermal papillae, which is this projection of the dermis, right, that sticks up here. So neutrophils in the dermal papillae, often there's associated edema, which can sometimes cause a subepidermal blister. But unlike bullous pemphigoid, these are grouped vesicles that are very itchy in a patient with gluten-sensitive enteropathy. And under the microscope, we're seeing neutrophils, not eosinophils. And if you were to do direct immunofluorescence, we would see a granular deposition of IgA molecules, kind of where these neutrophils are sitting, kind of at the tips of the dermal papillae.